Hello, I am here at the ESC in beautiful London. I have with me my good friend Scott Solomon from the Brigham and Harvard. Scott, welcome.
Thanks, Silly.
Tell me your title. What are you doing at the Harvard?
So I'm a professor of medicine at Harvard Medical School and Edward Frohlich Distinguished Chair at the Brigham and Women's Hospital, which is now Mass General Brigham.
So I want to congratulate you. I know, everybody's been waiting for the fine arts trial to get out there. And it's got that F, like Fidelio, and it's different. Why is it different? Why is it different than Spiro?
Well, Finerenone is a different type of drug than Spironolactone or Finerenone, so it is a non-steroidal mineralocorticoid receptor antagonist in contrast to the steroidal ones. Chemically, it's quite distinct. It's got a number of different properties. It's got a shorter half-life. It's actually more selective for the MR receptor than Spironolactone. It's also has a more balanced distribution between the heart and the kidney
than the
steroidal MRAs. And so the properties are definitely different. It doesn't also have any of those nasty sexual side effects that you get with Spironolactone. So for that reason,
clearly a different,
clearly a distinct drug. It is not truly in the same class. It's the same. It hits the same receptor, but it is a different drug.
So you've been chasing the HFpEF patients like forever. What made you do this trial in the way that it was constructed?
We've learned a lot of lessons along the way. I mean, we started really looking at this population with a CHARM trial many years ago.
Tell me about it.
We did TopCat, and TopCat was a interesting trial that had its problems, without question. We did Paragon, we did Deliver, so this is about the 5th outcomes trial that I've been involved in. And we did this trial because we believed in this mechanism. We believe that mineralocorticoid receptor antagonism could be beneficial in this disease. We already had fantastic data, as you know, in heart failure with reduced ejection fraction. We had some data from the TopCat trial. Now, TopCat was a problematic trial. As you know, when we unblinded that trial, we saw that there were really people enrolled, geographic differences, people enrolled who probably didn't have heart failure, didn't take the drug, many of them. And then, in post-hoc analyses, you see if you cut out the people who you think didn't have heart failure, it looks like maybe there's something going on.
But it also mirrored Paragon in the sense that as you went up on ejection fraction, which is
we saw that also in, I saw it in TopCat first, we saw it in CHARM, and we saw it in
CHARM as well.
Yeah, this attenuation of a treatment benefit as you go up in ejection fraction. But I'm pleased to say we did not see that in fine arts.
That was going to be one of my questions.
Yeah.
Differential in ejection fraction.
I don't know necessarily why. We didn't see it with SGLT2 inhibitor and Deliver with dapagliflozin either. And I think probably there are some differences in the way we treat our patients that are accounting for that. Now, we will present more data on this particular topic at the Heart Failure Society of America meeting in Atlanta very shortly. But we don't see any heterogeneity in fine arts. Of course, you haven't asked me about the primary results of fine arts yet.
We're getting there. No, but I want the audience to really understand, why did we need another MRA? Why? Spiro is so cheap, 25 cents a tablet if you don't even have insurance.
It is cheap. But I think most of us felt, even those of us who were very much involved in TopCat, that it wasn't definitive. We were throwing out a whole lot of people in the trial. We were, so we ended up with a much smaller subgroup.
But it's in the guidelines.
It's in the guidelines as a weak recommendation. So the question is, can we do better? And I think that's important because, when we did TopCat and when those went into the guidelines, we didn't have anything else.
No, that was all.
And now at least in the European guidelines, SGLT2 inhibitors are class 1.
1A, yeah, and I'm sure that HACC
they will go up, and
it'll happen.
It'll happen eventually.
So how'd you pick the endpoint?
The primary endpoint for the trial was cardiovascular death and total heart failure worsening events.
Yeah, which included not just
hospitalizations, either hospitalizations or urgent heart failure visits. Because as you know, over the past decade or more, we've been taking more and more of these patients who we would have hospitalized previously.
I know, I do it all the time.
And we're treating them as outpatients in an urgent care setting. Intensely. Those are the patients that we are obviously trying to keep out of the hospital, but they would have been hospitalized in prior trials.
And in a country that it doesn't matter,
yes,
they could be put into the hospital.
They could be.
So your endpoint was?
We've been playing around with the different ways of looking at endpoints over the years. Time to first, total, meaning first and recurrent.
Cool.
And it turns out it probably doesn't make a whole lot of difference. The trial was positive. We had a 16% overall reduction with a p-value of 0.007 in the primary endpoint. If we look at the endpoint in the traditional way as time to first event, it's the exact same hazard ratio.
Isn't that interesting?
And even a better p-value.
Isn't that interesting?
Interesting.
Just looking, and yet we know that each of these presentations has different outcomes.
And has portends worse prognosis. Every time you're hospitalized, things get worse.
Tell me about the mortality.
So we did not see a benefit in mortality. Things went in the right direction for both CV death and all-cause mortality, 7% reduction. So numerically fewer deaths, which is good to know. You're not harming people.
That's a safety endpoint.
But, in HFpEF, we've never been able to hit mortality. Why? Because the event rates in these patients are low. We would have to do trials that are twice as long or twice as long, right? Or twice as big.
Yeah.
When we put, as you remember, DELIVER and Emperor Preserve together, we got a p-value of about 0.05.
Yeah.
For a 12%.
I mean, there's something there.
Yeah, if you wait long enough, I think you would see a mortality benefit.
We would have to have trials that last, 10 years.
Yeah. Can't do that.
Would you now tell the clinician audience that they should switch from Spiro and go for Finerenone?
Well, first of all, there's no indication as of yet for Finerenone in this population, so
the company will
it's going to go through the FDA, and they'll eventually get approval. And as you also know, Spiro is available to clinicians, but it is not approved by the FDA. In fact, there was an AdCom, if you remember, for TopCat, and they did not act on it.
Because no company was interested in taking it on. I mean, that's the only reason that it's not approved.
Clinicians need options, and the best evidence we're going to have now, I think, is with Finerenone in this trial. We know the dose, we know the type of patients we enrolled, and by the way, we use the highest dose that has been used of Finerenone, which is the 40 milligram dose,
trials.
In the patients with GFR that was over 60. I think that as an evidence-based medicine clinician or physician, I would say we should use the drugs that we have tested and we've tested and are positive. However, as a doctor treating patients, I know that I'm going to have access issues, and clearly
cost issues.
There are cost issues. That all has to be worked out. We don't know how that's going to work out.
And a lot of pharmacies look at the creatinine when you order that Spiro.
Yes.
Even in our hospital, the internal pharmacist will call me and say, "Did you see this creatinine? And you sure you want to put them on Spironolactone?"
Spiro has a number of side effects that can be really pesky, including gynecomastia, other sexual side effects, predominantly in men. Finerenone doesn't have that, but also the degree of potassium elevation was a little bit less in this trial than we've seen with the steroidal MRA trials. On average, it was 0.2. In the HFrEF MRA trials, on average, it was 0.3. Now, that doesn't mean you don't have to worry about potassium going up.
Well, a little less anxiety on the potassium.
You and I both know potassium is a double-edged sword.
Totally.
And
I like my K's around 5, actually.
And we saw a much higher risk of hypokalemia in the people on placebo.
Bad.
And so, the question is, can we tolerate a little bit higher potassium to not have hypokalemia, which we know confers
hypokalemia. I am more scared of hypokalemia than I am of a potassium of 5, which I actually like.
Yeah.
And plus, we got the binders.
Right.
So, we still have the binders.
We had only a total of 16 people who were hospitalized in the Finerenone group compared to 6 in the placebo group who for hyperkalemia, and no deaths due to hyperkalemia in either group. So I think we can mitigate the risk of severe hyperkalemia with these drugs.
I told you I'd be happy you had 45% women. That's an improvement. But the HFpEF is a female issue. Your age range in the trial?
Very broad. I think our oldest patient was 92. No, our mean age was 72.
I'll be looking forward to what else we look at in the trial. I hope you do analyze the women separately.
We are. A lot of stuff is going to come out. We're going to present at EASD in 2 weeks some data about the diabetes effects, not just in the patients with diabetes, but the effects on new onset diabetes.
Pre-diabetes.
For that, we're going to look at at HFSA. We've got 6 presentations and many more to come.
We will be there.
Excellent.
Scott, thanks for being here with me. And to my audience, I hope you've taken all these pearls, jot them down, and apply them to your patients. This is Ileana Piña. I'm signing off from the ESC.